afternoon. Welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is now my pleasure to introduce our guest speaker, Dr. Sudha Dirisanala. She is a third-year internal medicine resident at Northeast Georgia Medical Center. She earned her medical degree in India and has since developed a strong clinical foundation with a focus on patient-centered care. Dr. Dirisanala is committed to delivering high-quality inpatient medicine and plans to pursue a career as a hospitalist upon completion of her residency. Please join me in welcoming Dr. Dirisanala.
Good afternoon, everyone. I'm Sudha Dirisanala, one of the internal medicine PGY-3 residents. Today, I'm going to talk about anticoagulation and venous thromboembolism management in complex hospitalized patients and recently developed updates in DOAC guidelines and practical pitfalls. So I do not have any financial gain or interest with any institutions. So learning objectives for today: optimize anticoagulation therapy in complex hospitalized patients using evidence-based strategies, assess and mitigate bleeding and thrombotic risk to improve patient safety and outcomes, compare appropriately select DOACs based on patient-specific factors and clinical scenarios, apply recent 2025 DOAC usage guidelines to inpatient coagulation and VTE management decisions. So why VTE matters in hospital medicine? We know that thromboembolism, including DVT and PE, is one of the preventable causes of inpatient mortality, a major driver for readmissions, significant contributor for long-term morbidity, and a very core hospital quality metric we follow. According to recent CDC data from 2025, there have been 900,000 VTE events annually in the US, with 60,000 to 100,000 deaths per year. In that, 25 to 30% of PEs present as sudden death. And there is a 50 to 60% of VTE events associated with hospital during hospitalization are within 90 days of discharge. And also 30% recurrent risk at 10 years, highest in unprovoked, and highest recurrence around first 6 to 12 months. Coming to mortality and morbidity, so acute mortality with massive PEs, 30 to 50%, and submassive, like 5 to 10%. DVT alone does not have acute mortality, but there is a risk of progression to long-term complications, including post-thrombotic syndrome. There is a 20 to 50% after having DVT, patients continues to have chronic pain, edema, ulcers, and chronic thromboembolic pulmonary hypertension in 3 to 4% after PE, and also functional decline and reduced quality of life. Estimated 7 to 10 billion annually US healthcare costs. There's an increased length of stay, ICU utilization, readmissions, and long-term use of anticoagulation. So risk factors of VTE in hospitalized patient, coming to Vicho's triad, the patient at risk at venous stasis, including immobility, sedation, paralysis, heart failure patients, have endothelial injury from surgery, central lines, trauma, and in hypercoagulability states like cancer, sepsis, pregnancy, estrogen therapy, and other high medical population, advanced age, obesity, pre-VTE, and ICU patients. So coming to anticoagulation options in the hospital, like DOACs has been emerging. fraction heparin, low molecular weight heparin, and warfarin. So DOACs. So why DOACs are first line? Recently, there's a very lot of emerging evidence to use DOACs. So DOACs, including factor 10A inhibitors, apixaban, rivaroxaban, edoxaban, and a direct thrombin inhibitor, dabigatran. So the advantages are rapid onset. So the onset is like 2 to 4 hours. There is no requirement for the bridging. So we can use fixed dosing, no need of routine monitoring, low intracranial hemorrhage risk compared to the traditional anticoagulation like warfarin, fewer drug interactions, have shorter half-life, very easy to manage like peri-procedural management, and outpatient friendly. It does have limitations with renal clearance, so we have to adjust the dose in CKD stages, cost, limited data in extreme obesity, but growing evidence has been supporting we can use in extreme obesities greater than BMI 40 and greater than patients with 150 kgs and drug interactions. So the conditions where DOACs are first line, hemodynamically stable PE, DVTs, post-discharge management, non-valvular atrial fibrillation, cancer-associated thrombosis. So always put in mind that if there is a GIGU malignancy with a high bleeding risk, have to use cautionly, and we can opt for low molecular weight heparin. So when to absolutely avoid DOACs in mechanical heart valves, moderate to severe mitral stenosis, severe renal failure with creatinine clearance less than 15, are dialysis patients, triple positive antiphospholipid syndrome, and severe malabsorption. So this is the overview of practical comparison between different anticoagulation options. So onset, DOAC is rapid and low molecular weight is rapid, immediate with heparin. So we do not need any monitoring, regular monitoring for DOAC and low molecular weight heparin. So we're monitoring with anti-10A in heparin and INR for warfarin. So reversibility, rapid with unfractioned heparin and partial with low molecular weight heparin. In renal failure, the best is in hospital we use heparin. There is an limited evidence so far in extreme renal failure with the DOACs with creatinine clearance less than 15 and ESRD. In mechanical valves, so warfarin is the best choice of drug. In pregnancy, it's low molecular weight heparin. And ICU instability, with fluctuating clinical status, it's go with like heparin all the time. Outpatient is excellent with the DOACs and can also durable with low molecular weight heparin and warfarin. So this is the recent paper, the position paper, 2025 like guidelines to how to use DOACs, a practical guidelines on prescription. Do we need like laboratory testing, perioperative and bleeding management? So in this paper, they have described like how to appropriately dose DOAC selection and dosing, the judicious use of laboratory testing, management of bleeding, reversal strategies when patients bleed on DOAC, and safe interruption and resumption of around the procedures. So one, like how we like choose the anticoagulation, like first we have to confirm the indication why the patient need anticoagulation, followed by like assessing the patient factors, like kidney function, any liver problems, patient's body weight, bleeding, assess the bleeding risk, and matching the agent with the patient profile. And the most important step is reassessing daily during hospitalization, because the clinical status, anything can be changed on daily basis. So first, conforming indications for acute DVTE, stable PE, cancer-associated osmosis, DOACs, you can go for apixaban, rivaroxaban. For unstable PE, it's heparin. For atrial fibrillation, for stroke prevention, non-valvular AF, DOAC preferred. Mechanical valve or moderate severe mitral stenosis, warfarin is drug of choice. For prophylaxis, if there is a standard risk, low molecular weight heparin or low dose heparin. And high bleeding risk, do like mechanical prophylaxis always and assess the bleeding risk versus thrombotic risk. So this is the table. I got it from that paper, the currently approved indication for use of DOACs. So for VTE prevention in post-orthopedic surgeries, apixaban, we can use 2.5 milligrams twice daily. Rivaroxaban, it's 10 milligrams daily. Dabigatran, it's 110 milligrams, one dose, 1 to 4 hours post-surgery, followed by 220 milligrams once daily. So for VTE treatment, DVTs, we initiate with 10 milligrams apixaban, 10 milligrams twice daily for 7 days, followed by 5 milligrams twice daily. Can consider lowering dose to 2.5 milligrams twice daily if we needed anticoagulation beyond 6 months. For rivaroxaban, it's 15 milligrams twice daily for 21 days, followed by 20 milligrams daily and reduced to 10 milligrams beyond 6 months. For dabigatran, so I've been researching for dabigatran, we have to do like parenteral for at least 5 to parenteral, like with low molecular weight or fondiparenchyma, at least 5 to 10 days, then following the maintenance dose of 150 milligrams twice daily or 110 milligrams twice daily. The reduction is because of creatinine clearance. So coming to atrial fibrillation, it's apixaban, we start with 5 milligrams twice daily or 2.5 milligrams twice daily, depending upon the reduced dose criteria. That's serum creatinine less than 1.5 and age greater than 50. If we meet any two of them and weight less than 60, any two of three, we do the reduction dose. Rivaroxaban, 20 milligrams daily or 15 milligrams daily, depending upon creatinine clearance, if it is less than 15. Dabigatran, it's 150 milligrams oral twice daily or 110 milligrams twice daily, with the reduction dose is based on creatinine clearance. Another indication is stable atherosclerotic vascular disease. So we use rivaroxaban 2.5 milligrams twice daily, and we can combine with aspirin if there is any additional factor along with CAD or PAD. So after we have to assess patient factors, like have to individualize the therapy. In CKD, so different DOACs have different renal clearance. So apixaban is 27% renally cleared, where dabigatran is the highest, 80% renally cleared, with rivaroxaban moderately 33%. So in CKD stages 1 to 3, DOACs are effective and safe, and we have to like appropriately dose regarding like CKD stage. In CKD stage 4 and 5 and ESRD dialysis patients, so evidence is still like evolving, limited. The standard drug is like warfarin with good INR control, but there has been like recently in 2023 AF guidance introduced, like we can use like low dose apixaban in ESRD patients. So dabigatran, as I mentioned, like it's 80% renal clearance, so generally avoid in advanced CKD. Rivaroxaban, it's moderate renal clearance, limited, like have like very limited ESRD data. Next one is in liver disease, like patients with the liver disease, the vitamin K antagonists and low molecular weights are standard of care for VTE prevention, but with the recent clinical experience, DOACs have been more effective in the compensated cirrhosis with the child-pug scale A and B, class A and B. And when coming to advanced cirrhosis, where like we child per class C avoid like DOACs. We do not have like much data using DOACs in there. Assessing the bleeding risk, assess the patient is like actively bleeding, the thrombocytopenia less than 50K, recent surgery, GI lesion, intracranial pathology. If there is a high bleeding risk and the patient is like unstable, always go for like heparin. And if we if we need to have like lower intracranial hemorrhage risks, so DOACs are preferred over warfarin. And it's low molecular weight heparin in pregnancy all the time. In obesity and low body weight, so major guidelines from ASH, ASC, clinical trials support like DOAC use in broad body weights like greater than 40 BMI, weight 150 kgs without any need for drug level monitoring. So for the low body weight, adjust the DOACs dosage. And if we are concerned about like we are doing like subtherapeutic kind of thing, like always can consider doing drug level monitoring. In active cancer, so cancer patients are who like have high thrombosis and bleeding risk, especially during hospitalized and also peri-procedural setting. So current evidence shows like apixaban or rivaroxaban are preferred DOACs for cancer-associated VTE. But we have to be careful in like high bleeding risk cancers like GI, GU. So to be on safe side, we can also choose for enoxaparin. And we can consult like chemo for assistant if the patients are in like active chemotherapy and like thrombocytopenia. So mechanical heart valves, this is a classic example where we cannot use DOACs. So landmark trials like Realign demonstrated like higher thrombotic and bleeding events with DOACs versus warfarin. So current guidelines strongly recommend using warfarin for all mechanical aortic and mitral valves. So typical INR goal is like 2.5 to 3.5. In antiphospholipid syndrome, especially in the triple positive, DOACs has been shown inferior efficacy with higher stroke and thrombotic events. So VKS remains like first-line therapy all the time. Now, like this is a matching agent with clinical scenario, considering the patient factors. I have few scenarios here. So a patient with like massive PE in ICU, like instability. So we go for heparin for if we need like any procedures, anything like that, we can have like rapid reversal and procedure flexibility. So stable DVT with normal kidneys. So we can use apixaban or rivaroxaban DOACs. ESRD plus AFib, it's warfarin most evidence-based option, but recently we can also use like 2.5, the lower dose of apixaban. Mechanical valve, it's warfarin, and GI malignancy and DVT, low molecular weight heparin preferred, high bleeding risk but requires anticoagulation, unfractioned heparin for trite inpatient control. So reassessing daily during hospitalization, this is a critical, but it's often sometimes overlooked. So we have to assess every day once patient is on like anticoagulation, we have to assess is anticoagulation is still indicated, is it for prophylaxis, is any, during hospitalization, is any bleeding risk changed? And the renal function, that is the one thing it can quickly change during hospitalization. So AKI is common in hospitalized patients. So DOAC dosing what we are doing can become unsafe. So we have to reassess every day. Also look for any procedure plan, need switching the DOAC, and any timing based on the half-life, hold timing based on half-life. If bleeding occurred, reassess like risk benefit, look for like if reversal needed in any life-threatening bleeding. And also always plan for transitioning IV to the oral conversion, and look for patient can afford the DOACs, and patient education is important, and ensure follow-up on INR if it is warfarin. So coming to like DOACs and laboratory testing. So usually the major advantage of DOACs is like we don't need like routine monitoring, but there are few conditions we can consider getting drug levels, the monitoring. So if patient is having like major bleeding, will get like levels and all anticoagulation studies to look for like any residual effect. If patient needs an urgent surgery, so we have to get the levels to see do we need a reversal for going for that surgery, new or deteriorating renal impairment, extremes in body weight to see that do we have like therapeutic level, recurrence or extension of thromboembolism when therapeutic adherence is assumed, using concomitant medications that can affect, and also instituting thrombolysis for treatment of acute ischemic stroke or other indications for thrombolysis. DOACs, standard tests, PET, INR are like non-specific for the DOACs because they will be usually normal at therapeutic DOAC levels. There is no any standardized test like INR for warfarin for the DOACs, but still like we can consider reviewing APTT for dabigatran and PT for rivaroxaban in emergencies. And PT is generally like non-specific for apixaban. The most targeted assays include dilute thrombin time or occurrent clotting time for the dabigatran, and targeted anti-10A activity assays for apixaban and rivaroxaban. So we have to correlate these tests with knowledge of what drug and the dosage, the timing of the dosage, and patient renal function. So effective anticoagulation management is like always we have to continuously evaluate patients' bleeding risk, especially in the elderly and renal dysfunction. So the tools we use regularly is has bled and VTE bleed. So management of bleeding and reversal. So once patient has bleeding, so we have to, I'll go to the next slide, okay. Yeah, this like once patient bleed on DOAC, so we have to categorize this like mild, clinically significant or life-threatening bleeding. We'll initiate resuscitation measures. First, we'll get the blood workup for all the anticoagulation studies and drug-specific levels, APTT, T, and dabigatran level, and whatever drug it is, we're gonna get that levels. And stop the DOAC. And for minor bleeding, follow like local hemostatic measures, and we can assess again, and we can feel like whether we have to hold the next dose or like we can continue. In a significant bleeding, it's like hemoglobin down greater than 2 grams. So we can use oral charcoal if the DOAC dosage is less than 2 hours prior. Local hemostatic measures get like imaging to see the source of bleeding, and transfusion support with blood and platelets. If there is a life-threatening bleeding, so we can consider giving specific reversal agents. For dabigatran, we can use idarucizumab, and factor 10A inhibitors like apixaban, rivaroxaban, we can use adnexanet alpha. So they are not available all the time, and they are like very high cost. So we can also use other non-specific hemostatic agents like 4-factor PCC and activated PCCs. And we can also use tranexamic acid, can be considered as an adjuvant. So coming to perioperative interruption of DOACs. So recent approaches standardize DOACs interruption and resumption should be based on risk of the surgery and patient factor renal function. So the PAUSE study recommend first risk stratify procedure bleeding risk and also patient thrombotic risk, and hold DOACs before procedure according to the agent, creatinine clearance, and bleeding risk. So these are current approved like the holding DOACs before surgery. For apixaban, 5 milligrams BID, rivaroxaban, 20 milligrams daily, and with any renal clearance, we hold 1 day before and day of the surgery for low to moderate bleeding risk, and 2 days before and day of surgery for high bleeding risk surgeries. For apixaban, 2.5 milligrams BID, rivaroxaban 10 milligrams daily, and rivaroxaban 2.5 milligrams BID. So we hold 1 day before surgery and on day of surgery through low to the high bleeding risks surgeries. And for dabigatran, as it is like highly renally cleared, it's like 80% renally cleared. For dabigatran with renal clearance greater than 50, hold 1 day, for low to moderate, hold 1 day before surgery and day of surgery. For high bleeding risk surgeries, hold 2 days before and day of surgery. For creatinine clearance less than 50, recommended to hold 2 days before and day of the surgery. And for high risk, it's 4 days before and day of the surgery. Surgery involving neuraxial anesthesia, patients on DOACs. So guidelines and data from management recommended 72-hour interruption of factor 10A before surgery or until the direct factor 10A drug levels less than 30 nanogram per ml. For dabigatran, so they recommended like European guidelines recommended 72 hours, but however the PAUSE study recommended to hold like 96 hours for like moderate renal impairment, 30 to 50, to ensure safe levels. Usually no need of bridging with heparin or low molecular weight heparin for DOACs, as they have like short half-lives, and routine bridging usually increases bleeding. So resuming anticoagulation post-operatively, depending upon hemostasis, thrombotic risk, usually like 24 to 72 hours. If we were not able to resume like therapeutic dose, we can always bridge with low molecular weight heparin or prophylactic DOAC doses. Resumption after major bleeding. So across multiple observational studies and meta-analysis, resuming anticoagulation shows like improved survival with an acceptable bleeding risk. So the resumption of anticoagulation is always like individualized, depending upon, we have to see like thrombotic risk versus bleeding risk, the severity of the bleeding and etiology of the bleeding. It's like between like 1 to 6 weeks, depending upon severity and etiology, and also have to put in consider like patient preferences and what they want to do moving forward. So common pitfalls we do, like we in hospital practice, inappropriate DOAC usage. In mechanical valves, they are like absolutely contraindicated, so increased thromboembolism and bleeding with DOACs. And renal failure, inappropriate dosing. So many DOAC prescribing studies shows frequent inappropriate dosing in renal impairment, majorly like due to like renal misclassification. And also DOAC pharmacokinetics become like unpredictable in renal dysfunction. Overuse of bridging anticoagulation, there is no need, it's not recommended, shows like more harm, except in like we can use in mechanical valve and recent strokes. And failure to reassessing bleeding risk, daily hospitalization. So when patients is on DOAC, like the during hospitalization, like everything cannot change. The renal function can change, the drug interactions, and we have to assess bleeding risk. So we have to assess every day and have to adjust regarding that, balancing between thrombotic and bleeding risk in the patients. And inadequate discharge, education and follow-up, poor transition of care because of educational gaps, lack of follow-up, lead to like increased bleeding versus thromboembolic events, and non-adhering off-label dosing, inadequate transitions, increased complications. So I have few scenarios how we can use applying that guidance. So if we have a patient, elderly patient with renal impairment, so elderly patient with reduced creatinine clearance may accumulate DOACs and can lead to higher bleeding risk. So choose an agent like favorable renal profile, that's apixaban, because it's shown that we can use apixaban even in creatinine clearance less than 15. And review drug doses reductions based on creatinine clearance and body weight. And consider getting targeted anti-10A or dabigatran levels if any bleeding concern raises in like patients. The next one, patient with recurrent VTE on DOAC therapy. So have to see is confirm the adherence, have to see like there's a current dosing, evaluate for drug interactions and also absorption issues. Consider like if everything is like okay, like consider switching to low molecular weight heparin for 1 month and reassess again. So also don't forget to evaluate for any underlying malignancy or thrombophilias. The next one, like patient with active cancer and VTE. So prefer DOACs for most cancer-associated thrombosis, but have to use caution in GI, GU malignancies as they have like higher bleeding risk, and also assess interaction with the chemotherapy. The next one, patient with advanced liver disease. So like with patients, we have to have like child pug classes before initiating DOAC. It's shown avoid like DOAC in child pug class C. So use cautionly in B. So apixaban has like most favorable hepatic safety profile. So future direction, so evolving trials and evidences continues to refine DOACs in the setting of renal disease, obesity extremes, and specific thrombotic states. But guidelines continues to say like warfarin and VKA remain standard for the mechanical valves and through thrombotic APS, while DOACs predominant in other clinical conditions. Also, there has kept and like lot of evidence, emphasis on like individualized patient evaluation, multidisciplinary approach in a complex patients, and hospital anticoagulation stewardship programs to ensure patient safety and outcomes. So take-home points. Anticoagulation in hospitalized patients is complex. So DOACs are first line, but not in all the patients. Have to assess renal function, weight, drug interactions, and they must guide the dosing. Special populations require individualized decision-making. Proper peri-procedural management avoids unnecessary bridging. So avoid like common pitfalls using guideline-based and patient-centered care. So these are my references, and thank you. Any questions?
Thank you. If you're viewing online and have a question, please enter it into the Q&A section, and we'll be sure to ask for you. In the room, do we have any questions or comments?
Thank you, Sudha. That was a comprehensive presentation on a topic that's very relevant here in the hospital and outpatient setting, and as well as on boards, certainly presenting the guidelines.
Yeah.
I'm wondering about any strengths, limitations you noticed of these guidelines. And you mentioned there at the end, like the two specific scenarios where warfarin's preferred, but I'm also wondering about the quality of the evidence, like recommending against DOACs. Can you speak to that at all?
You were asked for the mechanical valves and
Yes.
so yeah, the strong guidelines, there is an realign guideline, like they compared like rivaroxaban with like warfarin in the mechanical valves, and it shows inferior and have like higher thrombotic and bleeding risks.
So it's compared to Xarelto?
Oh, I mean, like I didn't get you.
Oh,
sorry.
what was warfarin compared to in that study? Do you know?
Yeah, they compared like the patients who are on rivaroxaban, like versus like who are taking traditional warfarin. So patients who are on rivaroxaban have like higher thrombotic risk, higher thrombosis stroke events.
Okay, so maybe it's still a question if apixaban or Eliquis would be superior.
I think there is an. I don't think they have anything at this time. They didn't do it on apixaban.
That's okay. I think that would be a good thing to include
Yeah.
for future reference.
Yeah.
Just like the studies that are defining the guidelines and the limitations of those. All right, and I want to get at least two more comments from residents before we finish. So.
Thank you, Sudha. It's very, very important topic for us. So I don't know, I missed that, but is there different INR for aortic wall and mechanical aortic versus mitral?
No, it's like 2.5 to 3.5.
Because I don't know, means I'm not updated, but I think it used to be 2 to 3 for aortic. Not sure, but is it Dr. Gross? You know anything?
I think it is 2.5 to 3.5 for mechanical valves, especially for mitral because of the increased blood flow through those valves. Sudha, thank you so much for your presentation. That was very nice. I was wondering if the anti-10A levels that we get in the hospital, are those the same as the targeted anti-10A that we get for apixaban?
No, like they are like different. I don't think so far, like I don't think I have ever got those.
So I think I have done a case where there was a thrombotic event with a patient being on Eliquis, and we got some anti-10A levels, and those were elevated, showing that the patient was possibly therapeutic, but I'm wondering if maybe that lab test is different, if there's a specific one, but I can probably call lab today and ask if there's a targeted one that maybe is a sent out.
That was a great presentation, Dr. Sudha. Is there any guidelines telling us to select an anticoagulant based on the tumor burden, the clot burden? Sometimes we'll have like small PEs incidentally found. Do we actually have to start treating those clots?
You mean like what? Instant and
Of anticoagulants based on the clot burden. Very small PEs versus massive PEs. Like we know that we have to treat the massive ones, but do we have to treat the really small ones?
I think we can use like prophylactic dose of apixaban or rivaroxaban, the half dose 2.5 for the clot burden, and also like low molecular weight heparin.
So I just looked up the question, Dr. Gross, that you were asking. And Dr. Jadhav, for mechanical mitral valve, INR goal is 2 to 3. And for the aortic valve, it's 2.5 to 3.5. And then there is a new valve, which is called the Onyx valve, which sometimes they use in the aortic. In that, you have to maintain 2.5 to 3.5 in the first 3 months, and then you can go down to goal of 2 to 3. And that was a great presentation, Sudha.
Thank you.
Great presentation, Sudha. So I have a curiosity question. So, most of the research you presented was, I'm assuming, initial anticoagulation commencement, right? So, like, let's say you're at a hospitalist in a very small community, and there's a patient who gets admitted, low PESI score, hemodynamically stable on room air, but for whatever reason, the ball gets dropped. And now they've been there for 7 days on a heparin drip when they really could have just gone home on a DOAC. But let's say you get there and now you say, this patient doesn't have to be here. I'm going to discharge them, but they've been on the heparin now for 7 days. Do you have to still load with the Eliquis 10 BID for the 7 days, or can you say, hey, I'm going to give them the referred dose of Eliquis 5 today, and then turn off my drip, and then have them continue for 3 to 6 months, what is determined by, HEMONC or whatever?
I think once we do the loading dose, so we can go with a therapeutic dose.
Okay, sounds good, thank you.
Hey, Dr. Laura, I had the same question when I was rounding with G1 last month. And we had a pharmacy resident on the team. And she said, what they've observed in practice is sometimes they do the loading regardless of how long they were on heparin, because you have to be loaded with Eliquis also. I'm trying to look up, well, I haven't looked up, but I will look up that and the evidence for that, but that's what I've heard from pharmacy.
Thank you, Dr. Dirisanala.
Thank you.